The largest nerve in your entire body is about as thick as your thumb, and it runs all the way from your lower back down to your heel. When something starts pressing on it, the pain almost never shows up where the real problem is. You feel it burning in your calf or going numb in your toes, but the actual trouble is sitting up in your spine. Here's the part most people get wrong. They rub cream on the spot that hurts and wait for it to pass, when that cream can't even reach the place where the nerve is being squeezed. The good news is that once you understand how this nerve actually works, the warning signs become easy to read, and you'll know exactly when something is worth catching early instead of waiting it out. Quick thing before we dig in. If you want health explained clearly and honestly, subscribe and tap like so more people find it. The goal is 300,000 subscribers, and you're part of that. Checklists and short health posts go out on my Telegram, and the QR code is on your screen now. So let's start with what this nerve actually is, because the name gets thrown around a lot without anyone explaining it. The sciatic nerve is the biggest nerve you have. It's built from several smaller nerve roots that branch off your spinal cord low down in your lower back and the area just below it, where your spine meets your pelvis. Those roots join together into one thick cable that drops down through your buttock and runs along the back of your thigh, heading all the way down toward your foot. Think of it as the main power line for the back of your leg. Signals travel down it from your brain to the muscles in the back of your thigh, your calf, and your foot, telling them when to move. And signals travel back up it too. It carries feeling from the skin across almost the entire back of your leg and most of your foot. That's why this one nerve has so much control. When it's working, you never think about it. When it isn't, you feel it in ways that are hard to ignore. A little further down behind your knee, that thick cable splits into two smaller ones. One is the tibial nerve and the other the peroneal nerve. And from there, they go their separate ways to handle different muscles and different patches of skin in your lower leg and foot. Here's why that matters to you. Because everything traces back to those same roots in your lower back. A problem in one single spot up there can show up almost anywhere along the whole line. You might feel it in your lower back, you might feel it deep in your buttock. It might run down the back of your thigh, settle in your calf, or land only in your foot. Different people, different spots, but very often the same root cause sitting in the lower spine. Now, how does this usually begin? The pattern is so common, it's almost predictable. It often starts as a dull, pulling ache low in your back. Nothing dramatic. You figure you slept funny or did a bit too much the day before. Then, over days or weeks, that ache slides into one side of your buttock, a deep, nagging soreness that sometimes burns. From there, it keeps traveling, down the back of the thigh, into the area behind the knee, down into the calf, and finally all the way to the heel and the toes. Plenty of people describe the sharp version of this as an electric shock. You stand up, you bend over, you cough, or you just take a step the wrong way, and a jolt of stabbing, burning pain shoots straight down the back of your leg. Often there's numbness riding along with it, or that pins and needles tingling feeling in your toes, like they've fallen asleep and won't wake up. There's a description that comes up again and again in clinical notes. People say it feels like their toes aren't even there anymore, like they've turned to cotton or wood and they can't feel the ground properly underneath them. The longer this drags on, the heavier the leg starts to feel. People describe it as filled with lead or strangely cottony, and real weakness can creep in. Climbing a flight of stairs gets harder. Keeping your balance on uneven ground gets harder. And after a long walk, the leg can feel like it's burning, an overheated, raw kind of ache in the muscle and the skin. None of this is in your head. It's the nerve telling you that something along its path is under pressure. Here's where a lot of people lose time, and it's worth slowing down on. When the real trouble is sitting deep inside your spine or buried in the muscles and ligaments around it, a cream rubbed onto your skin simply can't get to it. It might take the edge off how things feel for an hour, but it does nothing to the thing that's actually pressing on the nerve. So what is pressing on it? Very often it comes down to a disc. Between each of the bones in your spine sits a small cushion of cartilage called an intervertebral disc. Its job is to act as a shock absorber. It spreads the load evenly across your spine and softens the impact every time you walk, step, or land. But when that disc takes too much load or the same load for too long, it can start to deform. The soft inner part shifts backward, bulges out, and begins pressing right on the nerve root as it exits the spine, the very root that feeds into your sciatic nerve. Once that happens, no surface treatment is going to fix it because the pressure is coming from the inside. There's a case from clinical practice that shows exactly how this plays out. Picture a man, let's call him James, who hasn't exercised in years and spends most of his day at a desk. One weekend, he decides to help a friend move and goes to lift a heavy dresser. No warm-up, no thought about technique. His back muscles aren't ready for it. They seize up in a sharp spasm. The disc takes a sudden hit and shifts, and in that exact moment, he feels a sharp, shooting pain in his lower back that fires straight down his leg. From the outside, it looks like he simply threw out his back. But underneath, the structure around that nerve root has been disturbed. And here's the catch. If he does nothing about it, the swelling and inflammation around the root can keep that pressure going long after the original strain. What felt like a one-time injury quietly settles in and stays. That heavy lift isn't the only way this starts though. Sometimes it's simpler and sneakier. You sit on a cold surface for a while, or a draft hits your lower back and the muscles there clamp down and spasm. A muscle locked in spasm can squeeze the nerve branches running near it, and that's where the classic feeling of a leg that's fallen asleep comes from. The back pulls, the buttock aches, the leg prickles with pins and needles, and it just doesn't quite do what you tell it to. Now here's something most people never connect to their back at all. When one leg hurts, your body protects it without asking your permission. You shift your weight onto the good side. You favor the sore leg. You change the way you step. Do that for long enough and your whole walk reorganizes itself. A limp shows up. Your pelvis rotates or tips to one side. One leg can even start to seem longer or shorter than the other. Not because anything actually changed in the bone, but because of the way the pelvis is now tilted and one joint is being overextended to make up for it. The muscles along your back that hold you upright get dragged into this too. They're forced to work unevenly, stretched and overworked on one side, locked in chronic tightness on the other. That imbalance shifts the position of the bones, discs, and ligaments in your lower back even more, which only adds to the pressure on those sciatic nerve roots. There's a well-documented pattern in everyday practice that captures this. Someone, say a woman named Linda, walks with a slight limp for years because of pain in her hip. Nobody thinks much of it, but that constant tilt in her pelvis slowly builds into a full-blown squeeze on the sciatic nerve, complete with numbness running down her leg. The hip pain she ignored became a nerve problem she couldn't. That brings up another major source of all this, a worn down hip joint. Arthritis in the hip, old injuries, certain inflammatory conditions, any of these can wear the joint down over time. And to take pressure off a painful hip, a person naturally starts adjusting how they hold their pelvis and lower back, which loads the discs and ligaments unevenly. The discs begin bulging backward, they tug on the surrounding tissue, and they irritate the nerve roots. And now you've got inflammation and sciatic nerve symptoms that all started with a hip that was hurting somewhere else entirely. So far, we've mostly talked about pain. And pain is the loudest signal, but it isn't always the most serious one. The thing to watch much more closely is weakness. When your leg starts to give out, when your foot buckles under you, when you can't steady yourself on your heel or push up onto your toes, when you try to lift the front of your foot and it just won't come up, that's different. That's a sign the nerve isn't carrying its signal properly to the muscles anymore. Pain is the nerve complaining. Weakness is the nerve failing to do its job. Heavy numbness is another flag worth taking seriously, and I mean the kind where you stop feeling not just your toes, but a whole section of your foot, your lower leg, even the back of your thigh. When a neurologist examines someone in this situation, they often find that certain reflexes have dropped off or disappeared entirely. The knee-jerk reflex or the one at the ankle behind your heel. That tells the doctor something important. It means the connection running from your spinal cord through the nerve to the muscle isn't just feeling off to you. It's measurably weaker on an actual physical test. And then there's the most serious level of all, the one you really need to know about, even though most cases never reach it. The sciatic nerve roots sit very close to other nerve roots that control your bladder, your bowel, and the feeling in the area between your legs. When those get caught up in the problem, a specific set of warning signs appears. Doctors call them red flags, and they change everything. We're talking about sudden trouble starting to urinate, a feeling that your bladder never fully empties, losing control of your bladder or bowels without warning, numbness in the saddle area between your legs and along your inner thighs, and weakness showing up in both legs at once instead of just one. This particular situation has a name. It's tied to a bundle of nerve roots at the bottom of the spinal cord that fans out a bit like a horse's tail, which is actually what its medical name means. And specialists treat it as a true emergency, the kind where surgery may be needed quickly because waiting too long carries a real risk of permanently losing function in the legs and in the bladder and bowel. The medical literature includes cases that show why this matters so much. There's a documented pattern where a person, think of someone like Mike, puts up with months of pain and numbness shooting down one leg and never gets it checked out. Then one morning, he simply can't get out of bed. The leg has gone numb and unresponsive, and suddenly he can't urinate properly. At that point, the only option left on the table is urgent surgery. And here's the hard truth in those records. Even surgery doesn't always bring the function fully back if the nerve roots were squeezed for too long. That's exactly why the goal is never to let things get anywhere near that point. Which brings us to painkillers and why leaning on them for years is a trap. Pain pills and injections can genuinely dial down the pain and calm the inflammation around the nerve root. That part is real, but they don't touch the reason the nerve is being squeezed in the first place. So what happens? You feel better, so you go right back to loading your spine, lifting things you shouldn't, sitting hunched for hours, carrying on as if nothing's wrong. Meanwhile, the disc or the joint underneath keeps wearing down, completely undisturbed. Guidelines for managing low back pain make this point plainly. When pain hangs around longer than a few weeks, and especially when numbness, weakness, or changes in how you walk join the picture, it's no longer a rub some cream on it situation. It's a reason to get a proper, targeted look at what's going on. Skip that and you can drift without noticing from the occasional bad episode into constant, chronic pain, real limits on how you move, and a genuine risk of lasting damage to the nerve itself. So what actually happens when you go get it looked at? When you sit down with a neurologist or a spine specialist about back pain that's shooting down your leg, the first thing they do is ask a lot of questions. When did it start? What sets it off? Which direction does it travel? Is there numbness, weakness, any change in your bladder or bowel? Then they examine you, testing your muscle strength, checking your reflexes, mapping where you've lost feeling, and doing specific tests that gently stretch the nerve to see what reproduces your symptoms. All of that helps them narrow down which nerve roots are likely involved. When it comes to actually seeing the problem, the gold standard is an MRI of the lower back. MRI stands for magnetic resonance imaging, and the simple version is that it gives a detailed picture of the soft stuff, the discs, the ligaments, the nerves themselves. It can show a herniated disc, a narrowing of the spinal canal, which doctors call stenosis, or any unusual growth pressing where it shouldn't. A regular X-ray can't do this. An X-ray shows bone, the position of your vertebrae, and any obvious deformity. But it can't show you how a disc is pushing on a nerve root or how tight the canal around your spinal cord has become. Now, doctors don't send everyone for an MRI on day one of back pain, and that's deliberate because most back pain settles on its own and doesn't need a scan. But the guidance is clear that when those red flags are present, or when pain stubbornly hangs on with neurological signs like numbness and weakness, the bar for ordering that scan should drop low. That's how you catch the rare but serious cases early, the ones that need a surgeon, not just pills and stretches. And if the scan points more toward a worn hip joint than a disc problem, it makes sense to bring in an orthopedic specialist to judge how far gone the joint is and what the options are. Once there's an actual diagnosis, most specialists start with what's called conservative treatment, which simply means trying to fix things without surgery as long as there's no emergency forcing the issue. That can include a mix of approaches: medication for pain and inflammation, medication to ease muscle spasm, sometimes a targeted injection near the nerve, physical therapy, gentle hands-on techniques, and a course of therapeutic exercise. But here's the key thing to hold on to. Which methods and which specific medications make sense is a decision only a doctor can make for you, based on your exact diagnosis, your other health conditions, your age, and what your body tolerates. This isn't a one-size-fits-all checklist. And the guidelines stress something a lot of people skip right past. The bigger part of a lasting result usually isn't the pills at all. It's the change in how you live. Building up gradual, regular movement. Strengthening the muscles of your back and your core. Bringing down extra weight if it's there. Fixing your posture and rethinking how long you sit. That's the part that actually changes the odds over the long run. The people who specialize in rehab, physical therapists, and exercise instructors usually build their programs around a few clear ideas. They use movements that gently lengthen the back of the thigh and the muscles of the buttock, that strengthen the deep muscles wrapped around your spine, and that steady your pelvis so it stops tilting. The logic is straightforward. The aim is to get your body to the point where any ordinary load, walking, bending down, picking something up, gets spread out evenly so the discs stop taking a direct hit in the same spot over and over and stop squeezing that nerve root again and again. You're not just calming the current flare-up, you're changing the mechanics so it has less reason to come back. There are a couple of things worth being genuinely careful with, especially before you actually know what you're dealing with. There's a strong temptation to just heat the back up fast, rub it hard, get an aggressive massage, and force the tension out. But if what's underneath is a real disc herniation or a narrowed spinal canal, that aggressive heating and deep kneading can actually swell the tissue around the nerve root and make your symptoms worse for a while, not better. That's exactly why a lot of specialists say to clear any intense work on your back or buttock with a doctor who has already seen your scans and has a clear-eyed read on the risk. There's one more thing in this category that surprises people. Injections into the buttock muscle. The older medical literature documents real cases where a poorly placed shot damaged the sciatic nerve because the needle landed too close to where the nerve runs, and the result was pain, numbness, even weakness in the leg afterward. So how and where any medication gets injected is another thing that's smarter to work out with a trained professional rather than going off some piece of advice you picked up secondhand. And this is really the heart of why rehab matters so much, rather than just cycling through rounds of pills and shots. If you only ever do the occasional course of medication but leave the muscles of your back, your stomach, and your buttocks weak, and you keep living the same mostly seated life, then the mechanics loading your spine never actually change. The discs keep absorbing the maximum force in the exact same segments they always have, and even after a treatment course that seemed to work, the symptoms can circle right back around. But when you slowly build up that muscular support, loosen up your hips and your upper back, and learn to lift things properly and manage how long you stay seated, you're creating conditions where the disc and the nerve root genuinely get some relief. It takes weeks, sometimes months, and there's no shortcut here. But observational research consistently points the same direction. This is the approach that gives the best odds of fewer flare-ups down the road and better function over the long haul. A quick word on age, because it does shape this. As the years go by, your spinal discs lose some of their water content and get less springy, which makes them a bit more prone to bulging or tearing. And that risk tends to climb, especially once you're past your 40s and 50s. At the same time, worn hip joints and other age-related changes become more common, and those can shift the mechanics of your pelvis and lower back in ways that feed right back into this whole picture. So here's something I'd actually like to know from you, and you can drop it in the comments. How old are you? And how big a deal is lower back pain that shoots down your leg in your life right now? Knowing that genuinely helps me figure out which age groups to make more detailed videos for and where to put the focus. So what can you actually do with all of this starting now? Let me walk you through it as a set of steps worth taking to your doctor. The first one is honestly the most important, and it's a mindset shift. Be straight with yourself that regular pain and numbness in your leg, that heaviness, those jolts when you stand up or bend over, especially if they've gone on for weeks or months, are not just a normal part of getting older. And not just some vague thing you write off as wear and tear. The guidance is consistent on this. Pain that sticks around, weakness, and numbness aren't signals to grit your teeth and tough it out. They're signals to book a proper visit with a specialist. The second step is to show up to that visit prepared. Before you see a neurologist, write down a detailed picture of your symptoms. When it started, where the pain travels, which positions make it worse and which bring relief, and crucially, whether you've had any episodes of trouble urinating, any unusual numbness in the saddle area between your legs, or any real weakness in your legs. That information helps the doctor zero in faster on the serious possibilities, including that horse's tail emergency we talked about, where every week that slips by counts. The third step is to talk through imaging at that appointment, specifically whether an MRI of your lower back makes sense, and if a hip problem is on the table, whether the hip itself should be looked at too. The guidance supports getting that MRI early when pain comes bundled with neurological signs or red flags, and your doctor can tell you how much that applies to your particular situation. The fourth step kicks in once you actually have a diagnosis. That's when it's worth sitting down with your specialist, whether that's a neurologist, a spine doctor, a neurosurgeon, or an orthopedist, and mapping out a longer-term plan. Which medications might be used in short courses? Which physical therapy methods are actually justified for your specific diagnosis? Which exercises a rehab specialist would start you with, and which ones to carry forward to keep you steady? And the fifth step is to take your daily life seriously as part of the treatment, not as an afterthought. Your sleep, your weight, how many hours you spend sitting, how your workspace is set up, how much you move during the day, all of it matters. The simple, systematic things tend to carry the most weight here. Walking regularly, exercises that strengthen your core, taking real breaks from sitting, and lifting heavy things with a straight back instead of a rounded one. All of that takes load off your discs and nerve roots, and most specialists will tell you to treat these changes as part of the actual strategy, not as something optional you'll get to eventually. Let me pull the whole thing together so you walk away knowing what to watch for. Pain that begins in your lower back and gradually works its way down the back of your leg toward your heel or toes, burning jolts when you move, that pins and needles feeling, numbness, heaviness, and weakness in the leg, those are the classic signs that the sciatic nerve or its roots are involved. That's not a cream and forget it situation. It's a reason to plan a visit and talk about getting a closer look. When weakness starts climbing, when the leg won't hold you, the foot buckles, your balance drops off sharply, and it comes paired with heavy numbness, that's a more worrying level, and it's the kind of thing doctors view as a risk to the nerve itself. Don't sit on it. And if you ever get symptoms involving your bladder or bowel or numbness in that saddle area between your legs, trouble urinating, loss of control, that specific numbness, that's the situation where specialists say to get help immediately because it can point to the horse's tail emergency and time is everything. With your doctor, it's worth covering 3 big areas. How complete the workup needs to be, including whether you need that lower back MRI, a hip assessment, or other tests. Your options for treatment without surgery, taking your other health conditions into account, and a real plan for rehab and lifestyle change, so you're not just muffling the pain, but actually taking the strain off your discs and nerve roots. And keep this in mind above everything else. Everything I've shared here is information to help you have a smarter, more confident conversation with your own doctor. Not a treatment plan, and not a stand-in for being examined in person by someone who knows your full health story. If this helped you make sense of what's going on with your back and your leg, subscribe and leave a like. That's how this channel keeps reaching more people. 300,000 subscribers is the goal, and you're part of getting there. The checklists live on my Telegram, so scan the code on your screen.